Good morning. My name is Sandra Sanchez-Reilly, and I am a geriatrician and a palliative care physician. What that means is that I take care of older adults, and I also take care of people who are very sick. Many of them die, and this is what the talk is about. We're going to talk about end of life, and we're going to apply it a little bit towards veterans. And with funds provided by central office at our VA, we were able to produce the video that I'm going to show you a few months ago. And the video tells the story of a veteran who is undergoing a terminal diagnosis and how he and his family deal with all the issues. The patients and families in this video are actors. But there are some people that you will recognize that have worked in this facility. So they actually wanted to do this, and I think it's a wonderful production. And after that, we'll have some questions, and we'll talk a little bit about, specifically about last hours, what's expected. I also wanted to tell you that if you wanted to improve your knowledge in geriatrics and palliative care, we will be having our intensive course. It's called Pearls for the Clinician, and it will be August 28th to the 30th at La Quinta Inn. And so there's some more information in the back if you all want, but just wanted to let you know that. So with that, we're going to go ahead and start the video.
My husband was diagnosed with pancreatic cancer 6 months ago. It spread to his bones. He began to have kidney problems and weight loss. He'd been receiving hospice services for the last month, but he began to have a lot of pain in his back, pain in his abdomen. My son felt that we had to take him to the ER.
Hi there, Mr. Martinez.
Hi.
We're gonna have you right in here in this room, okay?
Oh, this room?
You're all right with that?
This room? I've been here before.
The ER nurse gave me a complete history of Mr. Martinez, including that his pain level was at a 9 out of 10. One thing she didn't mention was Mr. Martinez's code status. Unbelievable. How could you not know? Hello, I'm Ashley. I'm the floor nurse. How are we feeling today?
Can you give him something? He's in a lot of pain.
Well, I spoke with the ER nurse recently, and she said he was experiencing a pain level of 9 out of 10. Is he still at a 9, or has it worsened?
I think it's still a 9. He was in hospice, and when my husband started having a lot of pain in his back and in his abdomen, my son just freaked out and brought him to the ER.
I didn't freak out. I didn't.
Okay, maybe not freak out, but you acted just like your father. You get all shaken. You don't know where to go or what to do.
Well, Dad was looking bad. I wanted to do something.
I know, mijo. I'm glad you did.
But they both seemed very calm when I spoke with them about Mr. Martinez's pain.
He had him on some morphine, but because he's been in so much pain, we've used up all we had. You must have some more morphine here.
Well, I can take a look at his chart again, but I don't think he's ready for more morphine just yet. Hang in there, okay? We're gonna make you feel better, all right?
Excuse me, Ashley, can I see you for a minute?
Pardon me, please.
It's not uncommon for there to be a lack of training with situations involving hospice patients. Many aren't sure what to do or what steps to take.
I've never thought that I'd have to deal with a patient in hospice who's dying. I didn't want him to die on me, you know? And it had only been a few weeks since I'd graduated, and we had never talked about how to approach a patient who's dying.
I reassured Ashley to take it one step at a time. First, control the pain. This is going to take a morphine order.
Well, is that necessary? I mean, I know he's in hospice, but I don't want to kill him.
If you administer the right dose, you won't kill the patient. Plus, morphine is not just for dying patients. Mr. Martinez is in severe pain and he needs some relief now. Plus, see here. He used to be on 30 milligrams of morphine sustained release 3 times a day, so he's used to it. What I don't seem to find is his code status. Do you know what it is?
I'm not sure.
I'll tell you what, let's do this. You call the resident and get an order for the morphine, and I'll go talk to Mrs. Martinez.
Okay.
It was very reassuring to have the nurse manager come in and make sure what my husband's code status was, instead of making her own assumptions. It gave me the sense that the staff would do whatever it could to respect my husband's wishes in his final moments.
My dad was very clear and specific about his DNR. He wanted to go naturally and peacefully. The way God wants me to go, he said.
That is our priority with hospice patients, to respect their requests and, most importantly, to keep them comfortable.
Excuse me, Dr. White.
Yes.
I need to ask you for a morphine order for Mr. Martinez.
I have 3 Martinez patients today.
He's the hospice patient that came into the ER.
Wait, aren't they supposed to be at home if they're in hospice?
Yes, but he is in room 5. Dr. White started his residency in the acute care floor just a couple of weeks ago. And I think, just like myself, there was definitely a learning curve.
Oh, it's quite a history. Yeah, let's just give him some pain meds.
Okay.
Oh, hold on. Let's see.
Did you get a morphine order?
Yes, I'm just about to.
Okay. I was surprised at what Dr. White said next.
Yeah, let's just go ahead and give him 1 milligram of morphine IM.
We don't administer morphine IM. It's not only painful, it doesn't absorb well. Someone like Mr. Martinez needs an IV and a dose larger than 1 milligram. He was on morphine before. Dr. White, may I suggest we do it IV? Morphine IM doesn't absorb well and it's very painful.
I see.
I just spoke to Mrs. Martinez. Did you get the DNR entered?
Okay, I'm actually working on something right now. I'll be in with my attending in a few minutes.
All right, thank you, Dr. White.
Typically, a resident will communicate with his attending on any patients on the floor and any orders that need to be reviewed.
Are we capped? 9 admissions, right?
Yeah, and the nurse manager just talked to me about one of them. Mr. Martinez apparently is at a 9 in pain.
Mr. Martinez, he doesn't ring a bell.
Mr. Martinez, cancer of the pancreas, spread to bones, kidney problems, uncontrolled pain.
Oh yeah, he was admitted last month. We're no longer treating that cancer, am I right?
Yeah, I think so. I mean, I don't know what he's doing here. We can't do anything else for him.
Well, as clinicians, there's always something we can do. We can help with pain management and symptom control. We can help the family and the patient with important decision making.
I see.
Now, in the case of Mr. Martinez, we should get the palliative care team involved.
Palliative care team?
Yes, they know the patient. They can help with the family meeting we're going to have, plus they're very good at cancer pain management. Did you calculate the morphine dose?
Yeah, well, I mean, I tried. I got this pain card the first day of my residency, and I'm not really sure how to use it.
No worries, I'll help you with the information. And once the palliative care guys come by to see Mr. Martinez, they can confirm it.
Sounds good, thank you.
So let's look at that card.
I felt relieved when my husband received the morphine. I could see his face, his body just slowly relax. I even felt like I could finally breathe. I asked for a priest to be with me by my husband's bedside to help me pray for his peace.
He looks comfortable.
He is. It's been hard watching him suffer. He wants to go. He's ready. I just don't know what to do to help him.
Oh, just being here for him is really important. Remember that he can still hear you and feel you. Sometimes we don't really know what to say, and my suggestion is to start with the things that matter most. Please forgive me. I forgive you. I thank you. I love you. And goodbye. I know it's a difficult time, but I'd really like to talk with you and your family about your husband's wishes.
I think that would be best.
You're not going to believe this. I just got off the phone with Rita.
Rita's my dad's oldest daughter from his first marriage. Mom and I never really got along with her.
She hadn't been there for my husband the last couple of months. And it was just like her to come in wanting to make decisions and have her way. The palliative care doctor asked me if anyone had spoken to me about meeting as a family to talk about my husband's wishes.
Fine, thank you. Good. Did the nurse manager talk with you about having a family meeting today?
Yes, the nurse manager did. I think it's a good idea.
Okay, very well. And how about who should be here? Who else should be here?
I think my stepdaughter Rita would want to be there as well.
Is she the one out of town?
Yes.
Okay, very well. So as a group, I think we should all meet and talk about your husband's condition and his prognosis. Make sure that we follow his wishes to keep him comfortable. Things like what is the place that he's going to go to afterwards, and basically to follow his wishes.
My husband needs to be present.
Well, given your husband's current state, one of confusion and lack of consciousness, I don't think he'll be able to participate.
Did your husband share any of his wishes with you ever?
Yes, he said he wants to be comfortable and to die at home.
Mom, I'm sorry to do this, but I have to go back to the office. It's just falling apart with her.
Okay, mijo.
But don't wait for me to talk to you about what Dad wants. You know better than anybody else. Whatever you decide, I support.
Okay.
I love you.
Love you too.
I meant what I told my mother about trusting her with the important choices that she had to make. My mom and dad were married for most of their lifetime. They'd known each other since they were kids. They went to school together, worked at the same place. Nobody knew what was best for my father.
Will you all be there as well?
Absolutely. Our whole palliative care team will be there, the primary team will be there, as well as the nurse manager and the nurse who is taking care of your husband. We will all be there to support you.
During the meeting, we decided to try aggressive treatment.
No, you mean Rita made a big deal and convinced everyone and you to do what she wanted to do. Not even caring about your feelings or anyone else.
We had to rescind his DNR. We drew labs. We found out Mr. Martinez was septic. He was also in acute renal failure, which required hemodialysis. And now he has a severe episode of hypotension for which we're transferring him to the MICU. The palliative care team met with the MICU care team to talk about the next steps in Mr. Martinez's plan of care.
Good morning, everybody. As you know, we are here to discuss Mr. Martinez's case. I guess the best was to start is to go ahead and introduce ourselves. If we go around the table, Dr. Getter, he is our intensive care specialist. Mary, our intensive care social worker. Pat is our clinical nurse specialist from the palliative care team. Esmeralda is our nurse manager from the floor that Mr. Martinez came in. Janet is our intensive care nurse. She is being directly taking care of Mr. Martinez since his admission to the intensive care unit. And Elizabeth is our palliative care social worker. During the family meeting, speaking with Mrs. Martinez and Mr. Martinez's stepdaughter, Rita, they decided to pursue aggressive care, which, as you know, this goes against Mr. Martinez's wishes. He wanted to pursue comfort, so we have an issue here.
Furthermore, Mr. Martinez's current prognosis is very poor. At this time, he's in the intensive care unit, and he's intubated, he's on vasopressors, and he's on broad-spectrum antibiotics. In addition, last night, we actually had to dialyze him.
And Mrs. Martinez is not doing very well. She feels very guilty because she is not, and they are not honoring her husband's wishes. It's because of her daughter. Additionally, his pain level is a 6. We've increased his Versed and fentanyl drip, but he's still experiencing pain. His Levophed and dopamine are maxed out. I was wondering, what do you think about starting him on some morphine?
Actually, I think I'd rather just keep titrating up the fentanyl drip instead of mixing opioids at this time. What is the current status of Mr. Martinez's stepdaughter?
Rita left this morning indefinitely and said that Mrs. Martinez would be in charge from now on. Rita hasn't been involved in his health care in months and was shocked to see him so sick. She wants aggressive care, dialysis, life support, machines. She wants him to fight. She did say, though, before she left that she didn't think she would see him again.
What we need to do is we need to reinitiate the discussion about code status. At this time, with the vasopressors maxed out and the labs not improving, I think this would be a good time to reinitiate the discussions about DNR and comfort care. We especially need to look at stopping hemodialysis and undergoing compassionate extubation at this time. We need to be meeting with the wife daily about these issues.
Sounds good. Let me know when we have a meeting planned. I would really like to be there. I would like to be there for Mrs. Martinez to provide comfort and support for her. And so we're all on the same page. And I think that's it.
Sounds good to me.
Sounds like a good plan.
Good. Yeah.
Good morning, Community Living Center. Vicki Butler, RN. How may I help you today?
Hello, this is Nurse Ashley from 4A Ward calling to report on Mr. Mario Martinez. Last 4 social is 7826.
Good morning, Ashley. Glad to hear from you. We're expecting Mr. Martinez today.
Oh, great. So Mr. Martinez is a 65-year-old male with pancreatic cancer, admitted due to severe pain with a pain level of 9 to 10. He has required management with morphine IV, and his pain has now been controlled to a level 3. There was a family meeting today, and the patient is now in complete comfort care.
Okay, do you know his code status?
Yes, DNR, DNI. He currently has no infection control, isolation requirements. We're not really taking vital signs at this point, as his breathing is shallow and his pulse is slow. He's pretty much in bed and mostly sleepy, occasionally alert when he interacts with his family. He's eating very little, and of which is mostly soft foods and liquids. He is on morphine, continuous IV infusion of 2 milligrams per hour.
Okay, do you know when he had his last BM?
Gosh, I'm not sure. Let me look in CPRS for that.
Knowing when a resident had the last BM is very important for us here in the CLC. Lack of a bowel movement triggers a sentinel event.
I found it. Okay, he had a small, soft BM yesterday.
Thank you. Are there any family dynamics that I should be aware of?
Mr. Martinez has a daughter named Rita from his first marriage. She hasn't been very involved in his care up until now, and she doesn't really get along with the rest of the family. However, since the family meeting, she is more accepting of Mr. Martinez's situation. The decision maker is the patient's wife, Teresa Martinez.
Okay, Ashley, what is the patient and his family expecting from us here in the CLC?
The family has come to terms with the idea that Mr. Martinez is dying and that he needs to have full comfort care to die peacefully.
Okay. Well, thank you, Ashley, for your report, and we'll make sure we take great care of Mr. Martinez and his family. Have a great day. Thank you.
Thank you very much.
I wanted to surround my husband's room with happy memories, mementos that he cherished, everything that would help him feel he was close to his home. He was so proud of his service in the military. The hospice nurse took her time to help me understand the objectives and goals of hospice care.
I bought some aromatherapy. It's very calming and soothing, so I sit it over here. Thank you.
I brought some music he likes to listen to. Will that help?
Yes. Some of the things we do to keep our residents calm include music therapy, and a lot of times the residents will bring in their personal CDs. Our community living center is a place where we take pride in taking care of the veterans. When they're admitted to us, we do a full assessment of their spiritual, cultural, physical needs, social needs. We address all those issues. And our goal is to help them to maintain as much of their independence as they can in a home-like environment. So one of the things we do is reach out to our residents to tell us about their past, you know, what they've been through, what activities they like, what spiritual needs do we need to address for them, how can we meet them. We have a big chaplain service that has Protestant, any type of spiritual support that a resident would need. As far as their physical needs, we want them to maintain their independence for as long as possible. We also have physical therapy. Even though you're a hospice patient doesn't mean that you can't have physical therapy if you would like. We try to help them to maintain their dressing, grooming, eating for as long as possible. Relationships are a plus for us. We want them to maintain those relationships with their family members, with other residents within our facility, and also with friends that they have. So in other words, we're all about dignity and respect for our veterans, and whatever we need to do that, that's what we aim to do in the CLC. Each resident gets an assessment that addresses their spiritual and cultural practices to make sure that we don't miss anything when we're providing care for these residents. What this does for the families, we also have support groups for the families. This is done through our social workers. We have support groups that they can attend. Our residents also have the opportunity to journal about their life, end of life, their wishes, what they would like to have done in memory of them. So we look at all avenues to address the cultural beliefs and the needs of each resident. When residents are admitted to us from acute care, they're usually on IV morphine. But in the CLC, we use oral, sublingual, or usually subcutaneous. And this provides for the residents to have time to do activities that they would like. It's less invasive, and it allows them to spend time with their family in a non-restrictive way.
I thought my husband's final moments would be the scariest, where I would feel the most alone. But David and I were so well taken care of by the hospice team.
And she made sure to keep us informed every step of the way, even brought the chaplain to my father's side.
As a Catholic, I was worried that my husband had not received the sacrament of the sick. It was important to me and to my husband that his spirit be strengthened by God and that his spirit be ready at the time of his death. Thank you for coming, Father.
How is he?
He is continuing to decline, but I want to reassure the family that we're doing everything we can to keep him comfortable. Hello, Mr. Martinez. This is your nurse, Vicky. Ms. Martinez, as I stated earlier, his condition is declining. His breathing is slowing down and becoming shallow, and his blood pressure is dropping. You may notice his hands and feet are a little bit cool and blue. But just know that we're doing everything we can to keep him comfortable in his pain medication. Even if he can't respond to us, we have other ways of knowing if he's in pain. We can watch his facial expressions or his movements, and we will keep him medicated. And please let me know if there's anything else we can do for you. The moments leading up to a death, especially as a hospice nurse, I feel is the most time that we need to show the most compassion, most respect, the most caring. If the family is not there, we need to call the family so that we can tell them that we feel, based on our assessment of the resident, that the time is nearing. Most families want to spend those last moments with their family member if they're not there already. It's about making sure that our residents are clean. We want to make sure that their mouths are clean due to the thick secretions that have accumulated in their mouth. So many times we'll take a swab with a little mouthwash and just clean their mouth out, clean out as much of those thick secretions as we can. And we also will put some type of moisturizer on their lips. This adds another level of comfort for the resident, and it also gives the family some type of security and minimize that death rattle as much as possible. Residents are passing away. Many times they have the thick secretions that accumulate in the back of their throat, and they have a thick rattling noise. For the family, this is very discomforting and scary to them. During that time is nearing and the resident actually dies, we allow them to spend that special time with them. A lot of times the families are already there and we've already cleaned them up. We presented them to their families. And if we have a resident that we've had to do a lot of pain control and he might have some different pumps and tubes, we'll ask the family to step out. We'll remove those items, make the patient look very nice and presentable, and have the family come back in and spend as much time as possible with them. After they've spent as much time as they would like, that is the time that we have the family step out and we prepare them for the burial, which we have to do certain things like make sure that we clean them very well, and we have a different type of bagging we have to do for the morgue. We do that. And then we cover them, and then we place the American flag over their body. And this has been one of the most memorable things for our families. As we place the flag over, when we bring them out, we have received letters of how families have been touched because their loved one was a veteran and what it meant to them to have us honor them in that way. And a lot of times they will follow behind the recessional as far as they can go. And the other residents stop in the hall and salute the body as we go out with the flag. And for us as nurses, this gives us the chance to say thank you for letting us serve you.
It's very hard not having Mario around. And I know David misses him very much too. But I take comfort in knowing that we were able to be by his side in his last days, surrounding him with not just family, but with people who cared enough to do all they could to make his last moments peaceful ones. I'm very thankful for that. Thank you.
Yes, thank you.
I would like to read a personal written communication between a nurse and a patient, and this was taken from our hospice end-of-life care training. It says, "I need your help. I cannot do this alone. I know that when you come to see me, you think of me as some poor patient who will succumb to his terminal illness. You may have seen people like me too frequently, I am sure. I have tried to be a good man, a good husband, a good father, a good son. May you see me as more than just my disease. I have never been on this road before, so I don't always know how to respond. What's the proper etiquette for dying? Please know that I wish I could live longer. That I could fight harder against this disease. I am fearful of dying, of pain, and of prolonged suffering. Will you help me? Will you listen to me? And will you advocate for me when I cannot advocate for myself, so that I will not have to suffer needlessly?"
What do you all think? Did you like the video? See some teary eyes. We didn't bring tissues today. I'm sorry. Thank you. So as you saw in the video, some of the people that were part of the video are real people, of course, and we do work in this area all the time. And we meet some amazing veterans and their families who go through this process. All of us will. We go through this process. One's quicker than others, one's slower than others. But we all gonna go through this process, and we do need to learn how to take care of them. And so the video today, which addressed a lot of things, was about how do we do this? I mean, there's going to be crisis, and that's okay. There's going to be choices, and that's okay. And our job is to support them through the process. And then to learn these very small aspects of it. You know, where's the patient going to go? How is the patient want to die? Is the patient wants his family around? What kind of surroundings does he want to be in? What kind of things are important to him or her? And again, there's no small detail, because everything is important to the family. I promise you the family will remember the color of your tie and the way your hair was on when you delivered the bad news and when you went through the whole process. It has happened to me personally, and I'm sure to a lot of you, and it will happen to all our patients. So we have to be compassionate. All right, my presentation, which was half delivered by the video, will be about summarizing some of the aspects of the video, including physiologic symptoms, signs, and treatments as we approach patients at the end of their lives. And we wanted to talk a little bit about the different families concerned, and again talk about pronouncing the patient's death. So we have some terminology to talk about. The first one is the terminal phase. This is considered as the period in which you know for sure the patient is going to die. So it goes when the patient irreversibly declines until prior to the moments that the patient is going to die. And then the last hours, when we talk about last hours, are typically 48 hours, and there's no way for us to know, how many hours that the patient has. So when a doctor tells you your loved one has 3 weeks or 2 months, that's really not true. When we give prognostication for our patients, I always tell our fellows that we need to talk about intervals. Your patients has months to live. Your patients have weeks to months or hours or days. That gives the family a little bit of a timeline, but there's no way that we can really give numbers. Why it's so important to know about this? As human beings, we know that we need to prepare. And unfortunately, a lot of people are going to die, after having this very long period of suffering. And this provides opportunity to give closure, to finish any unfinished business, to create final memories and give final gifts and say goodbye. It's really important that we work with the patient and the family about this, so they can plan for the future and they can fulfill the patient's wishes. These are some of the trajectories that we need to talk about. So if we have the most common one, or at least the one that everybody knows, is cancer. So it will be on your screen, it will be on the red. And what it is that somebody has cancer, and you get diagnosed with cancer, and you get therapy, and if the cancer is very advanced, you continue to have treatment, and then one day the doctor will tell you, well, there's really nothing else we can do, which is a lie, and then the patient declines steadily, and eventually the patient dies. But what we see more and more, particularly in our geriatric patients, or patients that we see at home, or patients that have chronic illnesses, is this trajectory. And so on the blue line, you see illnesses such as COPD and CHF, in which they start here, they're disabled to begin with, and again, this is disability, and they're disabled to begin with, and then they have a CHF exacerbation or a COPD exacerbation. And they put them in the hospital, and they get treated, and they may go to inpatient rehabilitation, and then they go back to the way they were. Not quite though. They don't go back to where they were before, But then they are stable for a period of time, and then they go back to another episode and so forth, until eventually they die. Now, dementia is a little bit different, because in dementia you just have small ups and downs, and this is felt by the caregiver. So this is when the patient declines slowly but steadily, and you see that the patient starts being funny. They forget their keys, and they forget to turn the stove on, and everybody thinks this is hilarious and very common with the elderly. And it's not really true, it's not funny, and it's not common. It should be treated. And then they start to become aggressive with their family member, verbally and potentially physically aggressive. And then they go up, and then they go a little better, but then they go worse. Holidays come and go, and family shows up for a few weeks, and they're better during that time, but then they become worse and worse until they eventually stop eating and forget about their loved ones, and that then comes as an infection or an exacerbation of another condition. So again, these are some of the factors that we need to be aware of, and it's important that we understand so we can give some prognostication as well as talk to our families about what to expect. So as we again talked about the last 2 weeks of life, there are different stages, particularly over the days as if this progresses, and it's very, very stressful for the family and caregivers. And a lot of people give the family advice and second guess, and we think that they know what they're doing, and we have no idea. We, even healthcare providers, have no idea what to expect. So nobody knows anything, but everybody second guesses. It's really stressful. So in the early stage of those 2 weeks, the patient typically is bedbound. They lost interest and ability to drink and eat. This is a big deal for our patients. The majority of our patients are Hispanic. And you know how food and Hispanic culture goes. You've been in a lot of Mexican restaurants around here, so you know that food is really important. But in general, in all the cultures, food is very important because it gets us together, it reunites us, and we gather around food. We celebrate and we have cake. We have a celebration in our family and there's a meal there. So the inability for the patient to drink and eat is very stressful for their loved ones because they think they're starving them to death. Now, what we need to educate our families about is the fact that nobody is starving the patient to death. The natural course of illness, the way that the patient is dying, it's causing this lack of appetite to occur. So we need to make that natural and kind of normalize it, if you will, for our patients and families. Other signs that we see in our patients include sedation and lethargy, and sometimes what we see is delirium, which could be hyperactive or hypoactive. And we'll talk a little bit more about that. On the late stage, we see that they no longer are able to swallow. So you saw that Vicky on the video was administering morphine drops because at that time the patient may not be able to swallow pills or swallow bigger liquid amounts. So the other thing that we see is the death rattle. And again, the patient's muscles are so relaxed that they're unable to process the secretions in the back of the throat, the hypopharynx. And then as the muscle relaxes, the secretions start making a sound. And it sounds like, oh, blah, 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 blah. And it's really difficult for the family to hear that because they think that the patient is choking. So again, the patient really, we really haven't had, this is not that funny, but we haven't had any complaints from the patients about being suffering from that. Obviously, they can't talk. But we don't think that this affects their feelings. We do think that it affects their family, and so we treat it. So we try to dry the secretions. The patient also usually is in a coma. They may or may not have fever. They have an altered respiratory pattern, and this is also very impressive, not only for the family. What I've noticed is that nurses on the floor, they get impressed by the respiratory pattern. And they get impressed either if the respiratory pattern is very, very fast, the nurses are pushing the family to get the patient to a machine. And if the respirations are very slow, then the family is very concerned, and everybody is very concerned about, well, the patient is going to die. Well, the patient is going to die, and this is the way that it's going to go. Then skin color changes and eventually death. So what we need to provide for our patients is family privacy. We want to make sure that we have medications available to treat these symptoms and equipment as well. And we need to provide nurses support. We have had several patients in our palliative care service here in the tower, in which patients have been here for 3 to 6 months in the intensive care unit. And nurses, of course, get attached to those patients. So we need to make sure that we don't assume that the nurses or any clinicians is okay with this. And we need to, again, ask around and support ourselves as a team. And we need to have around-the-clock patient access for family, friends, and caregivers. So it is not okay to have visit hours on a patient who is actively dying. They can bring anybody they want, including children, and it's okay to bring children. So some of the options include home with hospice support, which is ideal. And if I ask you, if I ask you to raise your hand, what would be your preferred place of death? Let's see, home. Right. Hospital? Intensive care unit? No. 85% of all will die in an intensive care unit or a long-term care facility. So we need to make our wishes known. Hospital, in inpatient hospice unit, we know we have a unit here. I mean, it's a CLC, and VT is the nurse manager there, and they do a wonderful job to take care of taking care of patients who are terminally ill. And then other long-term care facilities also can have hospice support. So we also need to understand that there are different symptoms depending on if the diagnosis is cancer or non-cancer. What we really need to take from this is that when we have a non-cancer terminally ill patient, their trajectory is going to be less predictable, and so we're going to need to be more flexible for it. The other things that we've learned is that the other doctors that are non-cancer doctors, as they see the patient terminally ill, a lot of them push them to continue to having treatment. And so it's hard for you to balance, for the family to make decisions. So we continue to educate them. Okay, so this is Dr. Cicely Sanders, and Dr. Sanders is the founder of the hospice movement in the world. And she was a social worker, she was a nurse, and she was a physician. She started as a social worker and realized that she needed to learn about physical pain, so she became a nurse. And then she realized that doctors didn't listen to nurses, and so she became a doctor, and now everybody has to listen to her. She was a very strong woman, and she developed the first hospice in the world, St. Christopher Hospice, which still stands, and she died there on hospice. And she said, well, we have to address the needs of all our patients. And she said that there is this concept of total pain. And total pain is, yes, they have physical pain, and that's what medications are for. But in addition to that, it doesn't matter how much medication we give the patient. If we don't address the other types of pain, we will never be able to control pain and allow our patients to be relieved. So total pain includes physical pain, and when I'm talking about physical pain, that includes also other symptoms. So shortness of breath and other complaints from GI or fatigue. That's the physical pain. And then we have emotional pain, and emotional pain or psychological pain has to do with anxiety and depression and the loneliness and a lot of mental illness and difficult issues that our patients experience. The other type of pain is spiritual. And spiritual meaning finding meaning, finding hope, and of course, trying to resolve the unfinished business. For some of us, religion is very similar to spirituality, and for some of us, religion may not be the same as spirituality. And it's really important that we understand the difference and that we understand what the patients mean by it. And so our chaplaincy services are ready available to help our patients, but that may or may not be what they need. So again, we always need to ask, involve, inquire, what is the patient and the family want? And then the social pain, which again, all these three other pains, the emotional, the spiritual, and the social pain are all very close together. The social pain has to do a lot with, again, isolation and small chores, practicality, finances. What's my family going to do when I die and my wife is not really my wife, and then as I die I don't have my pension and she's not going to have my pension. What's going to happen to that? So that's a big deal. We have had cases in the intensive care unit, that hung out for a long time because they wanted to put their kids to college, and they lived on a ventilator for a couple of years because they really wanted to be able to continue to provide money for their families. who am I to judge? We just have to continue to work with them. But this is a big type of pain that some of our veterans will experience. When we manage a diagnosis, we have to have some general preliminary considerations. So particularly trying to switch medications to a non-oral route. It's funny how the patients come to the inpatient hospice unit with medications like Lipitor, which is lowering cholesterol medication. Well, if you're dying, I don't think that's necessary anymore. Or multivitamins, or so sometimes we laugh about that. Because again, they're pills about this big, and there's no way they will swallow, and there's no point for them to receive medication that they don't really need at this point. So we're all about taking off medications. And then we don't need to have the alarms or beeps. I mean, we know that their blood pressure goes down, so the patient and the family especially is going to be very alarmed about all these beepings and bells and whistling. And then again, limit notification orders to those necessary. So we don't want to keep doing numbers and labs and that sort of thing. Oh, that's the other thing. Our residents, especially July, new interns, new residents, they love to draw blood and check those labs. So again, there's no need. I mean, why do I need to know that a dying patient has a potassium of 6? I'm not going to treat it. So again, we stop a little bit and think about what we need. But the physical symptoms are definitely a plus, so we must evaluate them and treat them. So make sure, sometimes they have urinary retention, they may need a Foley, sometimes they need medications for secretions, for pain, and so forth. Now, let's talk a little bit about resuscitation. So there have been many, many studies about resuscitation. Should we do it, should we not? And so if I ask you, you are right here in the hospital, we have a co-team. If one of us drop here and our heart stops beating, what are our chances of survival? So I'll give you some percents and you raise your hand. 90%? Really? 50%? And you'll survive if you have an arrest right here in the hospital. 50% chance? I see some hands up. 30% chance? Some hands up. All right. So if we healthy people supposedly, drop here and there's a co-team readily available for us, our chance is about 15%. That's our chance. That's pretty good. I mean, here, if you are in the mall or somewhere else, well, you're pretty much doomed. But here, 15% is pretty good. So I mean, to start with, the chances are pretty low. But the problem is not that we get you back. The problem is that how do we get you back? You're not going to be back to your functional status the way that you were. So I invite you to think, what is important to you? And what's important to your patients? Is it important to have a heartbeat? Is it important to think? Is it important to have physical activity and be able to move? Is it important to interact with their family? So again, I invite you to think. And if anything you take out of the stuff, just think about this. What is important to me? Do I want to live? Which one? What do you do? He doesn't know. He doesn't know. Okay. He doesn't know. And so,
I will explain.
You can ask them to mute their mic. Could you please mute their mic? We're hearing you in somewhere.
You had to select one of those things. One of them was.
If you can hear me, can you mute your mic?
I selected. You want to select it?
Thank you. Okay, now I don't have sound. Okay, so our patients, particularly our terminally ill patients, can you hear me? No. Our terminally ill patients have a very, very low chance. The studies have said it's about 1%. If somebody is older than 75 and somebody has a diagnosis of advanced cancer, their chances of surviving are about 1%, 1 every 100 people. So that's very, very little. And from the 1% that survives, 90% of them will never leave the hospital. They will not go back to the way they were before. So again, having a patient who is terminally ill, offering resuscitation is really, really hard. Now the law says we should, but it's the way how we conduct the discussion. So if you bring your loved one to a hospital and a doctor asks you, do you want us to do everything? What do you think you're going to say? You brought him to a hospital. Of course you wanted to do everything. I mean, you do the best you can for your loved one. But if you give these numbers, and again, if you talk a little bit about what's important and what's going to happen and what are their chances, the discussion changes and they think about this. We have a project going on right now in the clinics in which patients now are able to make decisions while they are in the clinics, and now we explain this to them and we tell them, do you really want to be resuscitated? And they may say, you know what, I don't want to be resuscitated. I don't really need to end up in the hospital. And so you need to, again, complete advance directives and make your decisions heard. So when a crisis comes, you don't have to go through this process, so your family is second guessing, what is it that she or he really wanted? And then we have functional activity is going to be very decreased towards the few weeks before that comes. And so it's not like they have to be bed bound. If they are able, sitting in a chair is a great idea. If they can use the commode, let them use it. We don't have to like have them lying down all the time. But again, it's according to what the patient can do and is safe to do. We talked about the decrease in oral intake. It's normal, and we just have to let the family know how this goes. If we prepare them in advance, they won't be concerned. And guilt is a big deal in this process. So, oh, I'm going to starve them to death. Again, nobody's starving the patient to death. This is part of the natural process. So sometimes, so when oral intake is reduced, one of the things that so if the patient is eating or drinking something, it would be best if they do liquids. Thank you. All right. If things like soup or things with salt are good, try to avoid caffeine if you can, but if the patient only wants caffeine, I'm not going to take it away from them. No need to have low salt diet or diabetic diet, really. There's no important. It doesn't matter. At this point, it's whatever the patient wants to eat. Now, when the patient stops taking fluids, the family is going to tell you, how about IV fluids? And we could give it a try, but the problem is that as the systems shut down, especially the kidneys and the liver, the fluid is going to go to places that they're not supposed to. So there's going to be accumulating in the soft tissues that the patient will be all fluffed up. And then the fluid will go to the lungs, and the patient is going to be breathing faster and be more uncomfortable. So the IV fluids may not be a good idea towards the end of life, but we need to explain that to the family. They want to do something. So let's keep all this because I ran out of time. But what we need to do as a medical team is to explain to them, okay, well, you can comfort them, you can clean them, you can do different things, but you don't really have to feed them, and because again, unless the patient wants it. Now, it's important for you to understand that as the patient dies, there are two different roads that we take. And the normal road, which most of us will follow, is the road to death, in which you become sleepy and lethargic, and eventually you go into a coma and you die. And that's typically how most of our patients want. However, what we see a lot of our patients, particularly in our veterans with PTSD, is the difficult road to death. And this is, of course, in about 10 to 30% of the patients. And what we'll see is the patient becomes very restless. And then all these hallucinations from the past start coming, and they become very agitated, and they have hallucinations which are very vivid and very uncomfortable. And then eventually they have metabolic journeys and even seizures. So this is the road that we wanted to control because it's very disturbing for the patient and the family. And so a difficult road, medications such as benzodiazepines or neuroleptics are well used there if needed to be, and we're very comfortable with doing that. We talked about the death rattle, and we need to understand that pain is has a big presence in somebody who's terminally ill, as you saw on Mr. Martinez's situation. So we need to treat pain accordingly. Don't be afraid of using morphine or other opioids to treat pain, because this is what they need at that point. Now, we have to assist the family to try to let them stay there, and not only that, but give them a job. So if they are concerned about hunger, explain to them that there are other ways to nurture. If they're concerned about the thirst, keep them out moist, and give them a job to keep them out moist. And actually, we physicians and other clinicians, we have the power to tell them, this is your job, this is what you're going to do for your loved one. Speech, so the patient may not be able to talk, but you have to encourage that they can still hear you. Hearing is the last sense that goes away.
vision. So the patient may or may not be conscious, and again, encourage the family to be with him whenever. The patient doesn't have to be awake all the time. Hearing, again, is the last sense that goes away, and touch. So again, being able to give them lotion, like to rub their hands, if that's something that the patient would have wanted. Dr. Ross, who was our nurse manager in the video, mentioned these things that matter most. And it goes to a book by Dr. Ayurveda titled Things That Matter Most. And it says, tell your patients this, please forgive me. I forgive you. I thank you. I love you. Goodbye. We use this, and it's a very powerful tool in our consult service. Give the families permission to use this. Write them in a prescription. Write them in a piece of paper for them. This is obvious. I mean, of course you're going to tell them that. Not really. You know, when you're in this situation, families don't remember. And then what happens is that when you are minutes to hours away from that, you have the rattle, the mandibular movement starts to lower down, and then you have these cyanosis or the bluish skin or mottled pattern, and then eventually you have no pulse. As you die, as the patient dies, the respirations are absent, the pupils are fixed, the skin color changes, the body temperature will drop, and then the muscles relax. And we have to explain this to the family. And so as we think about pronouncing that, we don't really need to rub the patient's sternum for pain or anything. I mean, if there's no respirations or heart beating, we'll stop there. There's no need to have a big show in front of the family because, I mean, the patient is dead. And again, it's respirations and heartbeat. We have to comfort the family and complete the necessary paperwork. There is no rush. So as you deliver the news on the phone, you don't have to say, come back here, the patient died. Well, the patient died. So, you know, there's no rush of having to go through the process. Whenever the family is ready, whenever the family is available, we'll complete the paperwork and we'll follow procedures. It's important for us to talk a little bit about that with the family prior and tell them there is no rush, okay? And there's no, you shouldn't be guilty if you're not here, because some of the patients actually will die at their own time. They'll die whenever they feel like it, and the family may or may not be present, and that's okay. And then if needed to be, we communicate with medical examiner for selected cases. So we have to make sure that we are ahead of this and tell the family how this is going to go. And most importantly, we need to practice self-care because we have to deal with this very commonly in many, many situations. We also need to think about cultural considerations. There are some religions that don't want different sex people involved in their preparations. There are some religions that are not going to touch death on a Saturday. There are some religions that are going to want a priest to be present prior to die because otherwise the patient will go to hell. So again, as before, we don't want to have to catch up with them after the patient is dead and we made a mistake and it will haunt them for life. So in summary, that is a sacred moment in the life cycle. We will go through that, I guarantee you. Families will remember a person's death and how healthcare providers helped or not. As you saw in the video, there may be some crisis, and that's okay. It's part of our job. It's not a difficult family. They're just dealing with grief and loss. Healthcare providers can relieve the patient's suffering and ensure a comfortable death, however they wanted to proceed. The point of a family meeting and the point of our job is not to push our agenda. It's to follow along. It doesn't matter what is their path. The healthcare team can coach patients and families to the last hours of living, and we should do this in a prophylactic basis. And that's the end of my talk. I hope you enjoyed, and I'll be available for any questions. Thank you.